So, what does upper gastrointestinal tract bleeding look like? Acute gastrointestinal bleeding is a common medical emergency. It is responsible for over 65,000 hospital admissions in the UK. It's a life-threatening condition with a mortality of about 10%. Within the Royal Cornwall Hospital Trust, it's our bread and butter, and that is what we do. And I suspect that's the same throughout the country. So 80% of upper GI bleeds don't need any intervention, okay? The bleeding normally stops on its own, all right? So this is a scenario. This is Margaret. She presented as a 69-year-old lady who suffers from osteoarthritis of the hips, for which she takes ibuprofen. She's a sole carer of her husband, who suffers from dementia. Now, in 2004, Margaret presented with a Melina stool, which meant that she had to be admitted into hospital for 3 days for treatment and assessment. We found that she had a duodenal ulcer, which didn't need any treatment, didn't need any endoscopic intervention, no blood transfusion, and no surgery, as the bleeding had stopped spontaneously. During Margaret's admission, her husband had to be admitted into a nursing home for the 3 days. Okay.
Our project is about patients like Margaret and working out a way how we could avoid admitting patients like Margaret to hospital. So our challenge was to accurately identify low-risk cases like Margaret by risk assessment in order to manage such patients in the community and avoid admission to hospital, using a high-quality, safe service that's better for patients. When we started on this 8 or 9 years ago, there were 2 risk assessment tools, one the Rockwall score and 2 the Glasgow-Blatchford score. The Rockwall score was designed to assess risk of mortality, and its use in identifying low-risk cases was unknown. The Glasgow-Blatchford score was designed to assess need for intervention, but it was only validated in Glasgow and not across the UK. So the first thing that we had to do was to validate the existing risk assessment tools, and we did this in a multi-centre fashion across the UK with colleagues from Scotland and North East England. And what we found was that the Glasgow-Blatchford score accurately identifies low-risk cases such as Margaret, and it's superior to the Rockwall score. It performs well in different geographical locations, and it's very easy to use as it employs simple clinical and laboratory data. And we published this in The Lancet a couple of years ago. We then went on to define the low-risk population in Cornwall in a 1-year study looking at every patient admitted with an upper GI bleed, and we applied the low-risk criteria of a Glasgow score of 2 or less and an age of less than 70. And we identified 20% of that cohort of patients admitted who required no intervention, and none of those patients died. We felt that these patients could have possibly be considered for management in the community without admission to hospital. And again, we published these findings a couple of years ago. We then went on to roll out our concept into real-life practice in a pilot study for 1 year. Again, every patient admitted to our hospital with upper GI bleeding, and we managed to manage 10% of our patients in the community without admission to hospital, applying these low-risk criteria. These patients had endoscopy the next working day. None of the patients required any intervention such as endoscopic therapy, transfusion or surgery, and none of these patients died. Again, we published this a couple of years ago. We've embedded this approach in our clinical practice over the last 5 years, and we've recently audited our data adopting this approach in clinical practice. So low-risk patients, 142 of them have been managed successfully in the community without admission to hospital. These are patients such as Margaret. None of these patients have died. None have required any intervention such as endoscopic therapy, blood transfusion or surgery. And 94% of the patients we've managed in this way prefer to be managed in the community without being admitted to hospital. We're just about to submit this data for publication as well. Nick.
Thanks, Harry. And you can see that this has been some very high quality research which has been proven in several areas of the country. And we know that one of the greatest challenges for the NHS is to introduce sustainable change. In Cornwall, we've actually developed an embedded sustainable change. It's taken us about 6 months to do that. The strengths, I think, in doing this was to have a really clear vision about the service that we wanted to provide. And that service and vision was informed by all the major stakeholders in the care pathway. So that involved not just us as gastroenterologists, but also the emergency care physicians, our colleagues in the emergency department, and acute GPs, and of course patients. When we were clear about the service we wanted to deliver, we then quickly realised that we needed to realign the structure of the gastroenterology service in the hospital to support this. And that meant having a gastroenterologist who was available at the end of a mobile phone, and rescheduling our list so that when the patient turned up the next working day, there's an available slot for them. There'd be an experienced consultant endoscopist to deal with their case and to review it. And in redefining the way we delivered our endoscopy services, it had a real positive knock-on, not just for these outpatients, but also within the hospital. And we found that our inpatient stay, awaiting endoscopy, was halved from 3.6 days to 1.2. Once we'd aligned our services, we then developed the care pathway, and this was a care pathway that crossed many borders and started in the patient's home and finished in the patient's home. How did we make it work? Well, we made it easy, and to make it sustainable, we made friends. We used a very friendly pathway. It's very easy to assess the patients. It's very easy to inform the gastro team. It's very easy to get the endoscopy done. We built relationships because we were dealing with a condition that has a 10% mortality, but many patients are fine. So we worked very closely with our colleagues in accident and emergency, within the medical admissions unit, and with the acute GP service. We got to know them, we explained to them the service, we attended their meetings, we went to their governance meetings, and we honed on education, education, education. And in addition, we gave them constant feedback, knowing that the patients who came through this service came to no harm. And it took us about 6 months to get that embedded. So we think we've developed a service that's better for everyone. We've had admission avoidance, and this is a very common condition, and we're stopping 20% of those patients coming in. It's very high quality treatment, and when we've done a patient survey, we know that 94% of them prefer it. In addition, we've redefined our service and made it better not just for outpatients, but better for inpatients too, and that's been entirely cost neutral. It's doing the same work, but at a better time. And we've managed to develop an integrated care pathway from primary care to secondary care, and that's really helped us build relationships for further developments in the future.
We think our project ticks all the right boxes. It's simple, transferable, safe, good quality outcomes, cost effective, avoids hospital admissions, and just by avoiding those admissions, we think it will save the NHS £6.5 million recurring every year.